Hello, everyone. My name is Dr. Caroline O'Leary, and thank you very much for inviting me to speak today. I'm currently working as a specialist oncology registrar in Ireland with a special interest in immunotherapy in the treatment of cancers and the treatment of immunotoxicity. And today I will be presenting on the management of toxicities using the ESMO clinical practice guidelines. So these are my disclosures. So I've used a case to frame the structures here just to illustrate some of these points. So a 75-year-old gentleman initially presented to the oncology department in December 22 and had a massive, rapidly growing mass over his right mastoid. He had a previously resected scalp squamous cell carcinoma removed in November 22, so only a month before, but unfortunately then had recurrent multiple areas of squamous cell carcinoma extending down his posterior neck with large swellings, and a biopsy proved that this was a cutaneous squamous cell which had metastasized to the lymph nodes. CT next confirmed a large involvement of lymph nodes, but no distant metastatic features. For a 75-year-old gentleman, he was in relatively good health, but unfortunately had a very significant history of ischemic heart disease with multiple stents and a previous myocardial infarction. And this made us reluctant to use chemotherapy as a first line due to the high risk of complications. He was otherwise a healthy man, never smoked, never drank, did have slightly poor glycemic control, which unfortunately was made worse, but I'll go into that later. This is an illustration of the patient's neck on first presentation, and this was a very rapidly growing mass, which was obviously starting to ulcerate around the back, so very, very difficult for the patient and his family. He was commenced on nivolumab, which is an immune checkpoint inhibitor, and started this every 14 days from February 23. He had a couple of small complications, admitted post-cycle 2 for an infection and acute kidney injury, and had some issues with myalgias and joint pains for which he was started on a low-dose steroid. He had ongoing deranged blood sugar levels for which he attended the endocrinology department. However, come December 2023, nearly 12 months after starting treatment, he was noted to have an almost complete resolution of his disease. And as you can see here, there's a huge improvement in the disease mass. The patient himself was clinically much improved. So the development of immunotherapies and the use of the immune system in fighting cancer is not a new concept. Back in the late 1800s, William B. Coley just noted that patients who suffered from erysipelas seemed to have an improvement, or one specific patient seemed to have an improvement in his sarcoma following recovery from erysipelas. When he then induced an immune response using erysipelas in other patients, he noticed a reduction in tumor bulk also. However, his findings were not widely accepted, and the use of the immune system fell more or less out of use until the discovery of far more detailed understanding of how the immune system works, in particular T cell development and its uses. The recognition and discovery of specific immune checkpoints, in particular PD-1 and CTLA-4 in the 1990s, opened the way for the development of specific immunotherapy drugs, which target these specific receptors. So the targeting of CTLA-4, first drug, ipilimumab, was only approved in 2011, with the first PD-1 drug, nivolumab, approved in 2014. So these drugs are extremely new and novel, but have rapidly started to be used in all aspects of treatment of chemotherapy. As a result of these findings, Dr. J.P. Arisen and Tasuku Honjo won the 2018 Nobel Prize in Physiology for the innovation and influence of these discoveries on cancer treatment. So when we talk about immunotherapy, it can involve any forms of treatment which are involving the immune system. So these can include cancer vaccines or adaptive cell treatments, but most commonly when we speak about immunotherapy, we are talking about immune checkpoint inhibitors, and it'll be these category of drugs that I'll be focusing on for the rest of these talks. As you can see from the list here, hopefully some of these drugs are familiar to some people. There's a range of CTLA-4, PD-1, and PD-L1, which is PD ligand drugs developed, and more and more being approved every day for use or every month. So the structure and the basis of these drugs is the immune checkpoint regulatory pathway, which is part of the system of checks that the immune system, in particular the T cell, uses to recognize own cells or non-pathological cells from pathological cells to be destroyed. Now, tumor cells have a way of inhibiting the T cell recognition of it as an antigen, in particular using CTLA4, which is cytotoxic T lymphocyte associated antigen 4, and PD1 or PDL1, which is the ligand, which is programmed cell death 1. And again, these are the two main domains the drugs we use focus on. So the mechanisms of action for both of these drugs are relatively similar. Tumor cells develop a PD1 ligand, which then binds to the PD1 domain on the T cell. This inhibits the T cell, prevents it from recognizing the tumor cell, and prevents it from destroying the tumor cell and activating. So by blocking the ability for PDL1 to bind to PD1, the tumor cell recognizes that the tumor cell is immunogenic and will destroy it as it would any bacteria or other pathological cell. In a similar way, CTLA4 blockade uses the B7-1 and B7-2 domain to bind to CTLA4 on T cells, which again prevents the T cells from activating and destroying the cell, while blocking the B7-1 and B7-2 with the medications we have available allows CTLA4 to bind, and T cells were then able to kill the tumor cells. So as you can see here, there's a wide range of different immune checkpoint inhibitors approved for use across a range of cancers, and the concept of tumor agnostic treatment is becoming more and more prevalent in cancer, where one drug can work on a range or possibly all the different cancer types. These can be used in a number of different structures also. So either as a monotherapy, which is used commonly in lung, is a dual therapy with another immune checkpoint inhibitor, quite often a PDL1 and a CTLA4 combined together, or very commonly now combined with immunotherapy, so that there's a dual action on treatment for patients being treated quite often with metastatic cancer. They are most prevalently used in the metastatic and increasingly so in the adjuvant setting following resection surgery. But neoadjuvant treatment is becoming also quite prevalent, particularly in melanoma and ongoing in lung. These drugs are also particularly useful for drugs that are not particularly chemosensitive, such as melanoma or renal cancers. And as you can see here, there's ongoing trial investigations into the combinations with immune checkpoint inhibitors with other drugs, such as other immune checkpoint inhibitors, target therapy, and radiation therapy. So back to my case of my nice gentleman, was doing extremely well, had an almost complete pathological response within 12 months of starting 2-weekly nivolumab. However, in January of this year, he presented to the emergency department with a 4-week history of shortness of breath and exertion and a new oxygen requirement. His CRP, serum reactive C protein, was markedly elevated. On investigations, his CT thorax showed multifocal, patchy, and predominantly peripheral infiltrates bilaterally, and he had underwent a bronchoscopy which showed normal findings with no infectious cause. So he was started on IV methylprednisolone with IV antibiotics, and his, unfortunately, blood sugars increased on the high-dose steroids, so tight glycemic control was required, and he had an admission of 20 days before being sent home on a tapering dose of steroids. So what was this? So unfortunately, the immune checkpoint inhibitor and immunotherapy drugs have their own set of unique side effects. So unlike chemotherapy, they don't cause nausea, they don't cause systemic symptoms, but they will often cause a unique set of inflammatory symptoms due to T cell dysregulation. And we call these usually immune-related adverse events. These can be quite challenging to differentiate as they can affect any system in the body. So colitis in the GI system, gastrointestinal system, hypopoiesis, so significant endocrinopathies, rash, or hypothetically can affect any system in the body. These can also be quite challenging to differentiate, as the underlying pathology is usually the same as a non-immunotherapy induced toxicity. So rashes can occur for other reasons besides immune checkpoint inhibitor, other drug changes. So trying to differentiate and treat this appropriately can be very challenging. And there is significant risks in the use of these drugs. It's been found in trials that more than 50% of patients treated with a PD-L1 treatment develop some form of rash in varying severities, while pneumonitis, which my nice gentleman was suffering from and started on steroids for, is the number one fatal toxicity in PD-L1 monotherapy, while myocarditis is the most fatal toxicity of a combination PD-1 or PD-L1 CTLA combination therapy. Hepatitis or cholangitis is also a common toxicity of immune checkpoint inhibitors combined with targeted treatments. So there can be serious side effects and risks with these. We try and mitigate some of these risks by doing a full history of comorbidities up front and trying to quantify the risk in giving these drugs, but it's often quite difficult if a patient has, say, a previous transplant or a previously known autoimmune condition. Full workup, including, sorry, there should be more details on the TSH and FT there, but the thyroid function, cortisol function up front, and glycemic index are checked for a baseline and monitored throughout treatment. A viral screen is always done up front, and then risk stratifying blood tests such as ESR or if patients at high risk of other dysfunction, specific investigations regarding that. So in order to guide the diagnosis and treatment of these, there's a number of different guidelines, but most commonly in Europe, we use the European Society of Medical Oncology guidelines, which gives an excellent breakdown of the common toxicities, diagnosis, and treatment and follow-up. These are developed using data gathered from a large number of clinical trials, which have been ongoing since the first approval of these medications. This is a list here of some of the early trials that were done in non-small cell lung cancer using a range of different immune checkpoint inhibitors compared to other treatments. But as you can see, there's relatively high grades of ongoing toxicity, and for a number of these drugs, grade 3 to 5 immunotoxicity, which are high and severe levels of toxicity, are evident across all trials. One of the most interesting and unusual things about immunotoxicity is they can really occur at any time. Some patients can get severe toxicity after only 1 or 2 doses, while it has been noted that patients can develop immunotoxicity symptoms months after their last dose of treatment. As you can see from the time to toxicity here, the range can be up to 127 weeks recognized in pneumonitis, 130 weeks in endocrinopathies, and 107 weeks in gastrointestinal. So once a patient has received this treatment, there's no real time when they're hypothetically out of danger to develop these, as far as we know, although obviously given the newness of these drugs, this advent is still being followed up. The structure of the ESMO guidance helps to diagnose and grade the immune-mediated adverse events, ruling out different diagnosis, selecting the appropriate immunosuppression strategy for higher grade events, and then evaluation after 72 hours. So the most important thing when it comes to recognizing and treating an immune-mediated adverse event is the grade. So we use the CTCAE grading most commonly, so the common terminology criteria for adverse events. These are very specific to each system, but on the whole, grade 1 is mild and can usually be treated relatively conservatively. 2 would be moderate, 3 would be severe and would always require hospitalization for supportive care, while 4 is life-threatening, grade 5 is unfortunately death related to the adverse event. And the treatment paradigms and the recognition of these are all dependent on the grade, and the continuation of the treatment is also very dependent on the grade. So this is an example of the pneumonitis algorithm for the ESMO guidelines. And as you see, each section is graded. There is guidance regarding monitoring, diagnosis, further investigations, and then treatment paradigms. The decision to continue the treatment versus hold is very also dependent on grade. And this is also, unfortunately, an issue when patients want to continue on with treatment, especially if they're having a strong effect, like my patient, whereas for their own sake will often have to stop. The cornerstone of all treatment of immune toxicity is steroids, usually high dose, and these can be given 1 to 2 milligrams per kilogram from usually grade 2 and certainly grade 3 or higher. Can be given PO at lower grades, but we would recommend IV and up to 2 milligrams in higher grades and severe. Cutaneous toxicities, as I said, different toxicities have different sections and different recommendations. So it could be treated conservatively with topical treatments initially, but then would require steroids further on. And as you see, there's a range of different types of eruptions that can occur with this. Endocrinopathies would often be the exception to this rule, in that patients would not necessarily need to stop the drug or be treated with steroids, as the endocrine dysfunction can usually be managed with replacement of any deficiencies or management of symptoms. Transient thyrotoxicosis is very common, where a patient transiently gets a high T4 level and then becomes hypothyroid and may need thyroid replacement at that point, but rarely do patients become symptomatic enough that their treatment needs to be held, or that they would need to be started on steroids unless having some form of crisis. So my patient, unfortunately, again presented back into the emergency department in March 24 with persistent pain in his upper and lower gums, which were very sensitive to hot and cold. He couldn't chew, he couldn't eat, and despite a course of antibiotics at home, his vital signs were relatively stable, but his temperature was raised. And on examination, he had pus at his gum line with no obvious other form of cause. So on review of his admission bloods, as you note here, he had a raised CRP, but he had an absolute neutrophil count of 0.01, so he was profoundly immunosuppressed. No obvious signs of infection, and no cause of his temperature was found other than his gums and the incredibly low neutrophil counts. So unfortunately, this turned out to be a prolonged neutropenia, which is believed to be secondary to the nivolumab. It's an isolated neutropenia, no other issues with other white blood cells, and ongoing temperatures and opportunistic infections became an issue the longer he continued to be neutropenic. He also had worsening glycemic control and was started on a number of immunosuppressive regimes, including IV methylpred up to 2 milligrams per kilogram, was then started on second-line immunosuppression with IV immunoglobulins and cyclosporin with broad-spectrum antibiotics. And the patient, unfortunately, had a very prolonged admission. Hematology review and bone marrow biopsy showed reduced myelopoiesis, which didn't have any obvious cause, and no other malfunction with the bone marrow. After 5 to 6 weeks of second-line immunosuppression, the patient's neutrophil count began to recover, and with GCF support has then subsequently fully recovered. So rare complications are rare. They're usually between 1 and 5%. Most commonly hematological, such as in this patient, neurological, ocular, or there can be overlap syndromes in particular. Rare complications, unfortunately, tend to be the most devastating. They have the most significant adverse event on patients. They can lose their vision, they can lose movement, they can become profoundly confused or cognitively disabled, and myasthenia, myocarditis, myositis overlap will require ICU admission, and unfortunately has a high level of mortality at nearly 60%. Another form of immunotoxicity similar to this would be refractory or chronic immunotoxicity, such as in this patient, which fails to respond to high-dose steroids within 48 to 72 hours. And at that time, second-line immunosuppression should be considered. Whereas a chronic immune-regulated adverse event is when symptoms persist or worsen as soon as the steroids are tapered, where they get an initial response, but then when tapering occurs, the symptoms reoccur. The question of whether to resume or to re-challenge treatment after a patient has suffered a significant immunotoxicity is one that is still hotly debated at all conferences. The ESMO guidelines recommend potentially a class switch. from between drugs or a re-challenge with the same class of agent, with very, very close monitoring. Under investigation is secondary prevention, where the immune checkpoint inhibitor is resumed with, let's say, a low-dose steroid for concomitant immunosuppressive therapy, but this is still very much under investigation. Further immunotherapy, the structures of neoadjuvant or adjuvant immunotherapy, TILS therapy, or immune checkpoint inhibitor combinations is still ongoing, and the programming of the immune system is not done. However, within the immune checkpoint inhibitor domain, obviously these immunotoxicities, in particular in the chronic setting, patients will do extremely well from a cancer perspective, will have lifelong side effects, which will lead to them needing support going forward. And the planning around this is going to be instrumental in treating this patient population in the future. So again, back to my patient, after all of his side effects, was it worth it? Well, this is what his neck looked like this week. He's had a complete pathological response. He has no evidence of any remaining disease on scan. And he, despite all the side effects, has done extremely well. So thank you very much for having me today, and I'm happy to take any questions in the following section.